Good morning, all. Or good afternoon, rather. It's a pleasure to have everyone here with us for the Health and the Public Interest Programs weekly Wednesday seminar on Zoom. And we have a special guest today, Charlea Massion. Dr. Massion is a good friend, farmed out in the program, so she'll be introduced momentarily by our student moderator. I'm just going to say a couple words about the program and how the seminar is going to run. This is a program that emphasizes the non-medical things that affect health and healthcare, specifically such things as social factors, ethnic factors, economic, etc. Basically, all those things that factor into our health and well-being. And this seminar is right in line with things that are important in that realm. So we have in the chat the URL for the website for the program. If you're interested in learning more about what we do, you can look at our website. We have information sessions that the public is invited to that you can link through the website as well. So the seminar is going to run for roughly 40 minutes. And before that, Sophie Burry, one of the students in the program this year, is going to introduce Dr. Mashin, and then we'll go for about 40 minutes of presentation with some involvement of students and audience if Dr. Mashin calls for it. And then we'll go to Q&A, which will be moderated by Sophie, first for students and then for the general audience. So without any further ado, I will turn it over immediately to Sophie.
Hello, everybody. As Dr. Myers just set up, I am obviously also very excited for today's chat. I think that um, it's going to be very interesting. Dr. Massion seems to have a fascinating resume and lots to offer, and so I'm excited for all of us to get to hear a little bit about that. But to kind of start things off, a little bit about her. She's obviously incredible. But basically, experiences spanned from, everything from being an MD and working in clinical settings to, doing academic work with like, at teaching or, I think a lot of volunteering and consulting. And I saw that on your resume, Dr. Massey, which, and kind of connecting with the community that I think you're also aiming to serve, um, which for me at least was very cool to see. And I think a lot of us in this class can also appreciate that as a goal and intention. But yeah, and so I think Dr. Masson, your career started about what, 40 something roughly in that ballpark years
Yeah.
ago. And I think that with that, obviously comes a great deal of experience and a great deal of time to shift your perspective and grow it and really, I think, emulate what it means to be a lifelong learner. Um, and, I think that one of the things that really spoke to me was just seeing this kind of interplay of both private and public sector work in a sense of, working in a hospital versus working in a community organization or I mean, yeah, anyways. And so along those lines, I think that this is going to be a very interesting talk. But Dr. Massian she did her residency and practice as an MD in family medicine for a bulk of her career. And then actually in 2012, switched over to, or became board certified in palliative and hospice care specifically. And so I think that is, at least to me, one of the things that I would be very interested to hear about today. And I hope that everybody else is also interested. And yeah, I think that that kind of covers the main things for me. Yeah, thank you. So Dr. Bastian, happy to turn the floor over to you whenever you're ready to go.
Ready to go. So thanks, Sophie, for the introduction, and to everyone for being here. Before we begin the slides, I want to thank each of you for writing about your personal experiences with palliative care and hospice. Dr. Myers sent me your responses without any identifiers, and I've read them all several times. I wanted to give you a brief and incomplete summary of what you wrote. At least two of you have serious illnesses yourselves and have had friends die, some with the same diagnosis as you have, others with different medical conditions. Someone had an elderly relative who kept repeating that she was ready to die, and you wondered if this was an expression of suicidality. One has or had a best friend who decided to continue maintenance chemotherapy for advanced cancer to prolong her life. Another of you had a best friend with stage 4 cancer who decided to stop cancer treatment and begin hospice care. As a young child, one of you and your family were present in the home of a grandparent when they died on hospice. Another of you and your music instructor played music for people in a community hospice facility, choosing music based on someone's spiritual or religious beliefs. Several of you have had elderly relatives on hospice care. You wrote that you were comforted by the holistic and compassionate care they received, but also expressed how difficult it was for the family when someone is dying. So your HAPI cohort has had many connections already to serious illness, palliative care, and hospice. And I hope our conversation today will help you reflect on your own experiences, as well as learn more about this area of medical care. So our topic today is to delve into where hospice and palliative care fit into the ecosystem of contemporary American healthcare. And two things that I'd like you to remember. One is palliative care is the fire department, not the fire. And what if palliative care could be given as an expensive monoclonal antibody drug? So Jennifer, maybe the next slide. So here's the outline. I'm sorry, I have a little fall stuffiness with all the leaves coming down. So we're going to go over the definitions of palliative care and hospice. We're going to talk about what is typical care when someone has a serious illness and what is typical care at the end of life. We're going to talk a little bit about the benefits of palliative care, both for inpatients, people in the hospital, and outpatients, people in the community. We'll talk a bit about what's provided on hospice care, and then we'll go into the barriers to growth of palliative care and hospice in the United States. So on to our next slide. So this is the definition of palliative care. Palliative care can be given for any stage of a serious illness. And serious illness has various definitions. It's generally for someone who has a 1 to 2 year length of life expectancy, or also called prognosis. An important part of palliative care is it is provided concurrently with curative care or life-prolonging treatments. And that would be like dialysis for kidney failure, chemotherapy for advanced cancer, cardiac surgery for someone who has advanced heart disease. And the next slide is about hospice care. So the Medicare hospice benefit became law in 1965, and the Medicare hospice benefit outlines many of the conditions for hospice care. So to be hospice eligible, somebody must have an estimated length of life or prognosis of 6 months or less. And that prognosis is estimated by someone who is a hospice medical director, who has experience with saying like, okay, someone has, New York class 4 heart disease. And so we know that someone who has that advanced heart disease, that it is likely that someone will not be alive 6 months from now. If someone is on hospice and they live through the 6 months, then they're reevaluated about what their prognosis would be for the next 6 months. On hospice, the care is focused on comfort and quality of life, and curative treatments or life-prolonging treatments are stopped. one of the ways that I think about palliative care is hospice is kind of the last phase of palliative care. It's hospice is part of palliative care, but there's a lot of care that someone can get before they have that 6-month prognosis. So next slide. So typical care in serious illness, and remembering that what is generally called serious illness is an advanced illness where someone has a 1 to 2 year life expectancy. Typical care, somebody sees multiple specialists, they go to like 5 different offices. They see their cardiologist, they see their nephrologist, they see their primary care physician, they see an ophthalmologist for their retinal problem. So it's a lot of many different physicians being involved, typically in someone who has serious illness. There's also a very strong emphasis on testing, blood tests, imaging, x-rays, CT scans, MRIs, medications, and procedures, biopsies, thoracenteses. There are many different invasive procedures that can come up when someone has a serious illness. And in palliative care, one of the aspects that we see is there's little or no ongoing review about the goals or values that someone has along the way, even if a major change occurs. The general path is, well, your illness is progressing, but let's still continue the treatment, and now we're going to add this drug, or now we're going to do this procedure. Now we're going to replace your heart valve. And so it tends to be very directed by physicians, and without asking, what do you want? The person who has the serious illness, what do you want? What's your quality of life? How are you spending your days? Are you able to do the things that you want? And then the next slide. So typical end-of-life care most often occurs either in a hospital or in a skilled nursing facility or other long-term care. And here are, in 2023, these are the deaths in the United States with the percentages of where they occurred. 38% were in the hospital, 20% were in a nursing home or long-term care. So that's like almost 60% of deaths in the United States that occur not at home. 30% do occur at home, and home may be, someone's the home that they had. It may be at an assisted living center. It may be at a memory care unit if someone has advanced dementia. And then 12% are unknown location, and these are mostly fatal accidents, injuries, overdoses, and unexpected deaths. I would say that surveys that have been done of United States adults, 70% of people say that they want to die at home. That is their choice of where they would like to be when they die. And as the last slide showed, 60% are in facilities, are in institutions. So there have been some strides in providing hospice care for people at the end of their life. In 2024, 53% of Medicare beneficiaries were on hospice when they died. And so that sounds like, oh, well, that's pretty good. At least half of people, and for Medicare, most of the people on Medicare are elderly, certainly not all, but most. But when you look deeper, their time on hospice was brief. And so 35–40% come to hospice care a week or less before they die. And 56% come to hospice care a month or less before they die. So even though people die on hospice, generally they continue aggressive care until a very short time before they die. And we see this typically in the community hospital where I work. Someone has had 5 admissions in 2025 for exacerbations of congestive heart failure. And so they've been in the ICU, and then they get a little bit better, and then they are discharged to a skilled nursing facility for short-term rehabilitation. And then while they're there, they get short of breath again, they become fluid overloaded, and they're back in the hospital. And so somebody often cycles through multiple hospitalizations, and then which are really difficult for people who have advanced illnesses. Being in the hospital is very stressful, both for the patient and for their family. I don't know what your experiences have been, but if someone's in an ICU and they're delirious, they have no idea what's going on. The alarms are going off, the lights are on 24/7, it's noisy. They're being taken care of by strangers. A lot of things that are not peaceful. They are not relaxed. There's that full-on aggressive care is still being given, and then the cardiologist may say, like, well, we just don't have anything else for you except hospice. And so then they're discharged to their home for the last 2 or 3 days of their life. I think we could do better. So the next slide. I want to talk about some of the benefits of hospice and palliative care because they're generally not well known. I work in our community hospital on an inpatient palliative care team. So at this time, I work just inside the hospital. I don't have what's called an ambulatory practice outside the hospital. So I'm in the hospital seeing patients who are often, critically ill. And palliative care physicians, if they're involved, symptom management is better. We have a lot of training in pain management and in management of other symptoms that you can see here: intractable nausea, difficult agitation, anxiety, depression. And so we're called in if the hospital physicians have kind of used all the medications that they usually use, and the patient is still having significant symptoms. So that's one of the important benefits that palliative care provides in the hospital. Palliative care also helps explore someone's what we call goals of care. So these are conversations that are with a patient and with their family if they want their family involved, and their family means anyone that is important to them, to take a step back from the microscopic details of what's going on, what their sodium was this morning, what, has their white count changed, what did their latest chest x-ray show. It's very easy in the hospital to get immersed in the tiny details of someone's care and not taking a step back and looking, like, what's the overall picture? Is someone actually getting better, or are they getting worse? And regardless, what do they want? What's important to them? Palliative care, and this includes the physicians and also our palliative care nurses, we help patients understand and complete advanced directives. So there is a form. I don't know if any of you have seen it. It tends to be printed on very, very bright pink paper. In California, it's called a POLST, which means Physician Orders for Life-Sustaining Treatment. In some states, in Massachusetts, I believe it's called a MOLST. And that is a one-page form that someone completes, and that is a very clear outline of their wishes. There are 3 sections in the post. The first one is their wishes about attempted resuscitation. If their heart stops or their breathing stops, do they want resuscitation attempted? Or, as we would call it, would we allow natural death? So that goes into effect just if someone's heart stops or if their breathing stops. Then the second section of the post is about their wishes of what intensity of treatment they want. Do they want absolutely everything done? Are there some things that they want done, like they don't want to be on a ventilator, a breathing machine, but it's okay if they receive IV fluids and IV antibiotics. And then the last section is about artificial nutrition. Does someone want to have a feeding tube? Does someone want to get their nutrition either supplemented or totally given by artificially? So once that is completed, and it's completed when it's signed by a physician who's had that conversation with the patient, and then it's signed by the patient, and then that becomes a legal document in almost all states in the United States. And that form goes home with somebody. So if they have, if they have some kind of crisis at home and paramedics come to the home, then their care is guided by what's on the post. The default, if someone doesn't have an advance directive, the default in the United States is you get everything, at that time. You get transported to the hospital, resuscitation may be attempted, you get admitted to intensive care. So if someone has a post, that is one effective measure to have someone get the care that they want and not have care that they don't want. 5 Wishes is a very friendly, user-friendly form. It is filled out by a patient with family involvement if they want that. It's signed by the patient, and then they have 2 witnesses. Only one can be a family member, the other one can be a neighbor. And that also indicates what kind of care they want and don't want. In the hospital, if someone has not designated a medical decision maker, that is someone, if they are not able to make their decisions on their own, or let's say they are making decisions on their own, but then they go into a coma, or they have a major stroke and they can no longer speak. Designating someone to speak for you is a very important part of being prepared for whatever lies ahead. So we talk things through. What are the responsibilities of a medical decision maker? Who would you want? Have you talked with them about your wishes? So we can help with that process. And then palliative care also is sort of by default. Often the palliative care physicians often are involved in coordinating other specialists. The patient may be seen by the intensive care physician, they're on dialysis, and their nephrologist comes in, they're being seen by someone from infectious disease. So, and those specialists may or may not be talking to each other. And so palliative care helps integrate the information from multiple specialties. Is that clear so far? Is that helpful? Anyone have any questions up to this point?
Sounds good.
Okay, great. Next slide, Jennifer, thank you. So there also are outpatient palliative care programs. And so that's palliative care that's given outside the hospital. So that will give you all the benefits that are in inpatient care that we just discussed. And also it will give you continuity of care and an ongoing discussion as someone's illness changes, as their condition changes, as their goals change. So that is also beneficial. Outpatient palliative care physicians also can also help with complex symptoms. So that is often beneficial. And the next slide. So alternatives to dying in the hospital. And here's a quote from me. And I often talk this over with patients in the hospital who say, like, you know, I don't want to come back to the hospital. I've just had it. It's terrible. It's hard on my family. It's hard on me. I've been in the hospital several times. And so I just would like to go home and stay home. And what I need to convey to them is, if you're not on hospice, it's unless you kind of die quietly and quickly, you know, you just die in the middle of the night in your bed and you're kind of found the next morning, you will be transported back to the emergency room and will be rehospitalized. If someone is in a skilled nursing facility and they develop, let's say, shortness of breath, skilled nursing facilities, when anyone has acute symptoms, their default treatment plan is calling 911. So even if someone doesn't want to go back to the hospital, if they have symptoms that are distressing to them and distressing to their caregivers, they are going to be headed back to the hospital. If someone is on hospice care at home or in a nursing facility, and they develop some kind of pain crisis, respiratory crisis, agitation, then either the family, if they're at home, or the staff in a skilled nursing facility or assisted living, they call hospice. Hospice sends out a nurse, and they can do that within a relatively short time, 24/7. If somebody can't breathe at 3 o'clock on a Sunday morning, 3 a.m., call hospice, and the hospice nurse will be dispatched, will evaluate the patient, talk with a hospice physician, and figure out how to manage those symptoms. So the next slide. So what we find is that most people, they do not know what hospice provides until they are on hospice. And many patients and families say, if we had only known what hospice was, what hospice provides, we would have come to hospice much earlier. So on hospice, somebody is cared for by an interdisciplinary team. That includes physicians, nurse practitioners, nurses, social workers, chaplains, hospice aides, who I call hospice angels, and volunteers. 24/7 access if a crisis comes up. And hospice, when someone signs the consent for hospice care, hospice also provides all their medications, all their supplies, medical equipment if they need a hospital bed at home, if they need a bedside commode, if they need a wheelchair. Hospice provides all that medical equipment, and it is in the home before someone, if they're coming out of the hospital, it's all there in place before they arrive home. So next slide. So thinking about palliative care and hospice and the benefits that we have considered, why is this kind of care marginalized? And so this is one of the central points that I want to make in this topic of where are palliative care and hospice in the ecosystem of contemporary medicine. And where we are is kind of like on the periphery until the very end. And this quote by Upton Sinclair, I think, is very cogent to understanding this. It is difficult to get a man to understand something when his salary depends upon his not understanding it. So on to the next slide. So as you probably have heard in your HAPI courses or in your own experience, and I know many of you have worked in different in different settings. I'm sorry, one of my cats just was approaching the screen. So United States healthcare is extraordinarily expensive, 3.9 trillion and growing. A huge chunk of it goes to hospitals. This 978 billion goes for physician services and other clinical services, and then $450 billion for prescription drugs. So there are many industries that have intense economic investment in taking care of people in the hospital who are really sick. And those corporations, pharmaceutical companies, benefit from people having this intensity of care for a long time. The next slide, please. So one factor, and I think it's actually related to the slide before, is there is a paucity of palliative care and hospice physicians. Hospice and palliative care became a board certified medical specialty in 2006. So we've had about 2 decades of board certified hospice and palliative care physicians. But in these 20 years since we became board certified in this area, in the entire United States, there are only 8,700 of us. Additionally, the access to specialty care training is very limited. So across the whole United States in 2024, there were only 180 to 200 hospice and palliative medicine fellowships. So for someone to go into a hospice and palliative medicine fellowship, they go to medical school, and then they can go into a palliative medicine fellowship, which lasts for 1 year. They can also go into specialty care. They can go to medical school, become a pediatrician, practice as a pediatrician for a length of time, and then take additional training to become a pediatric palliative medicine, hospice and palliative medicine specialist. And in the next slide, you'll see how this compares to cardiology. So in 2024, there were at least 30,000 board certified cardiologists, and 1,000 last year, 1,000 to 1,100 cardiology fellowship positions. So we have a really well worked out pipeline for cardiology specialists to be trained, to keep on training, to keep on coming. And they are very important, of course. And I work with cardiologists every day, but there are many, many more of them than there are of hospice and palliative medicine physicians. So it's difficult for people to access palliative care in their communities, and many hospitals now do have what they call a palliative care program, but a palliative care program is not a board certified palliative physician. It's a social worker who gives the patient and their family a pamphlet on end of life care. So that the access is quite limited, and it's really not getting any any better, not really improving. And I think that's, I think that is related to this focus on care that is given by, pharmaceutical companies, medical device companies, long stays in the ICU where you have, I don't know if any or all of you have been in an ICU in the last 5 years, but if you go into an ICU, go into a patient room, they're attached to several different monitors and they have, drips of 4 or 5 medications that they're receiving at the time. So it's very expensive care. It's very aggressive care. And the industries providing that care, are benefiting from that type of medical system. On to the next slide. So we hear about palliative care, maybe we ask, I go on ICU rounds, interdisciplinary rounds at my hospital, and we will be talking about a patient who doesn't have a palliative care consult, who has advanced illness, difficult to manage symptoms. And if I suggest, well, what about palliative care being consulted to help with the care of this patient? And we hear things like, well, if we involve palliative care, maybe the patient will say like, well, I don't want all this treatment that I've been given. So there's this fear, like if we even bring up the topic of empowering a patient and their family to consider their goals, that's sort of dangerous territory. And then we also hear, if we say the H word, hospice, then the patient may lose hope. It's like if we even bring up hospice as an option, the patient and family will feel that we don't have care to offer. Their condition is hopeless, and we just that would be too hard on them. As a longtime feminist, this whole scenario bothers me tremendously, that who is in charge of the care is not the patient and what they want and what their goals are. The care is in charge of is the responsibility, almost the exclusive responsibility of the physician, saying like, well, you didn't get better on this chemotherapy, but don't worry, we have another kind of chemotherapy to offer you, without any discussion in between about, do you want to have more treatment for your cancer, given how difficult your treatment has been up to this point. So any questions about that? Any comments? Anyone who's been involved with a patient, a family member who's been in the hospital? Maybe we'll get to talk more about this during the discussion, but feel free to jump in. And the next slide. So we're going to show this short video in just a moment. I want to mention that Jared Rubenstein is a pediatric palliative care specialist who works in a cancer care hospital in Texas. And I have heard him speak. He's very thoughtful, really funny. And these animations he sort of does in his home office in his spare time. And you can go to YouTube, Jared Rubenstein, and you can see a whole array of palliative care animations. He also has animations on other topics, including racism in medicine, sexism in medicine, and just I think is very very helpful for thinking about these issues. So in this video, the fire department is coming into a home that is on fire. So sort of the metaphor of a palliative care provider coming into a critical medical situation. So see what you think of this.
Hi. We got a call that this house is on fire. How can we be helpful? Well, the house is on fire, but I'm worried if you go in there it might send the wrong message. Wait, what? I'm with the fire department. Yes, I know. I think you could be really helpful, but I think the family might be worried something is wrong if the fire department shows up at their house. But something is wrong. Their house is on fire. Do you think there's any way you could talk to them, but not use the word fire? What? I just think if the family hears the word fire, they might lose hope. But I am with the fire department and I am here to help this family with their fire. Right, totally. I think you could be really helpful, but I'm just not sure this family is in a place where they're ready to meet the fire department right now. Can we call you the water support team?
So as simple as this video is, it does demonstrate what we often experience as palliative care providers, that even inviting us in to provide support for a patient and their family is sort of a dangerous thing. And if we bring in palliative care, they will lose hope. They will feel like, like at some point, even bringing up the idea that someone is getting worse or they might die even in the next several days is just too hard on everybody. So it's, patients and families know what's going on. And many of them, I would say even most of them, want to talk about their experiences and want to be asked to participate in their care. But the treatment team, the other physicians just see this as dangerous territory. We don't want them to give up hope. For about 3 years, I have participated in a heart failure quality initiative at our hospital. This is mainly with cardiologists, and they are still very reticent to refer patients to palliative care, even if they've had multiple hospitalizations during the last 6 months. Even if they're very frail, even if they have other medical conditions that are also diminishing their health. And sort of the truth is, getting back to the salary part of this, if a cardiologist puts in a stent in a coronary artery for someone the day before they die, they're still paid for that. That's still, okay. They still, and I appreciate this, they're still sending their kids to college on what they earn from being cardiologists. And the more interventions, the more procedures that are provided, that is directly related to their income. We're not, even with all the kind of, administration, even with all, there are so many analysts involved in palliative, in hospital care and in outpatient care, all these, goals and all these metrics. We still are not focused on outcome. We're focused still on what is done to someone. And then we have the last slide. And this is in honor of Dr. Fu Berman, who has apparently is somewhere in Italy as we speak. And this is the idea of what if palliative care was provided as a monoclonal antibody, as a very expensive drug that people would take. So you can take a look at this in terms of pharmaceuticals.
Since starting treatment, I've had pain in my fingers and toes. Can anything help? Have you tried palliative? Healthcare for my chronic illness has gotten so complicated. I wish something could help me navigate all my options. What about palliative?
I know there isn't a cure for my mother. I just wish something could help us make the most of her last days.
Have you considered palliative? Okay, so what's this palliative I keep hearing about?
Palliative is a treatment available to anyone with a serious or life-threatening illness. It can help with pain and other symptoms, planning for the future, making difficult decisions, and caring for you and your loved ones at the end of life. Side effects include increased comfort, having your wishes honored, less depression, less spiritual distress, and improved quality of life.
Palliative.
So Sophie, welcoming you as the moderator of our session, and questions and thoughts. Take it away.
Yeah, thank you so much, Dr. Massion. I think we all really enjoyed your presentation, and thank you for, first of all, laying things out so clearly. We also, I think your videos were lovely and a great illustration of some of the topics you were trying to discuss. And so I think that I can kind of turn it over to my cohort now in terms of questions. I think that obviously, I think some of us will have questions about some of the things we talked about. Others, I think in other seminars we've talked about just very broad patterns of health in the world, and obviously the slightly strange version of health in the world that we're living in right now. That is a bit different than what we're used to. So, yeah. And so, anyways, so if anybody would like to kick us off with a question, that would be great. But yeah, thank you. Sorry, Haley, go ahead.
Hi, thank you so much for this talk. It was really amazing and incredible and very informative. I just had a quick question in regards to hospice and palliative care. So I had a friend who was on hospice, well, palliative care first, and then moved into hospice. And her mom is still currently paying off the bills from hospice. So I was just wondering if you've noticed that like low income communities or like marginalized communities have a harder time accessing hospice or palliative care just because of the cost, or is it usually fully covered by insurance?
So that's a really good question. I certainly don't know the situation of your friend and now your friend's mother, who is still paying the medical bills after her daughter has died. Is that the situation? So for someone who has Medicare, when they sign a consent for hospice, Medicare completely covers all the services. So there aren't any extra charges. All the medications that someone needs are delivered to their home. The hospice nurse comes into the home or wherever their residence is at that time. And hospice aides come in, they provide, personal care, bed baths, getting someone up for a shower if they're able to do that. So that's what Medicare covers. And most insurances, I would say in my experience, almost all insurances follow the Medicare hospice benefit. So when someone says, I don't want to go back to the hospital, I don't want to continue hemodialysis, I don't want to continue chemotherapy, treatments that are intended to be either curative or to prolong life. They're not focused on comfort or quality of life. So someone who goes on to hospice is giving those up. If they're earlier in the course of their illness and they have palliative care, then they can continue their curative treatments. Most hospices do have a charity program. So if someone, let's say, is undocumented and they don't have any insurance, and that's the situation for many people who live in Santa Cruz County, where I practice. And so hospice raises money to pay for the care for someone who has no insurance to reimburse the hospice. So I would be interested if your friend's mother is paying off hospital bills or is paying off hospice bills. Because if someone has been in the hospital toward the end of their life, and then they move to hospice, they and their family are still responsible for all those hospital bills, which tend to be exorbitant. So I'm sorry that your friend's mother and family not only are grieving for the loss of your friend, but also burdened with sorting out medical bills and figuring out ways to pay bills without going bankrupt.
Thank you.
Cool. Trini, if you want to go ahead.
Hi, thank you again for your talk. It was really interesting to see all the statistics and perspective as well. One of the questions I had was about when you were discussing how palliative care and hospice are seen as kind of giving up or like triggering some sort of fear response or so I was wondering what were some effective ways that providers or healthcare professionals can help like destigmatize this and so that people who are near this decision making can see it as supportive instead of as giving up hope.
That's a very good question. Thank you. I think some of it comes down to educating physicians about what palliative care and hospice is, that it is not giving up. And one of the kind of secrets about hospice care is that people, and there's good research on this, when people go on to hospice, they actually live longer than if they continue aggressive care. So they are, they remain in a comfortable, more comfortable than the hospital setting. They have nursing care at home. They and their family have support from social workers, from non-denominational chaplains if they're interested in spiritual care. So with that kind of stable care environment, there is research that show that people with advanced lung disease and with advanced heart disease actually live longer on hospice, but that's not generally appreciated. So I think there is education of physicians and other health providers is very important, but I think that empowering people to ask for palliative care and hospice on their own is very possible. And this happens in the hospital. Someone will get a consult that says the daughter of this patient requested a palliative care consult. So families can ask for it. And if someone and their family is interested in just finding out what hospice is, and what care it provides, they can contact a hospice agency directly and get an information visit. There doesn't have to be the physician or any of the physicians taking care of someone does not have to be involved. And if they decide to go to hospice, that, hopefully their physicians will not argue with them, but will support them in that transition of care. Does that answer your question? Are there other parts of it that?
No, I think it does. Actually, coincidentally, I do work in an advanced lung disease clinic, so it's interesting to hear that patients on home hospice or hospice end up living a lot longer.
Certainly not everyone, but the research shows that, that a significant portion of people do. Another aspect of hospice that I didn't mention during our talk is that hospice can be provided in any setting that someone is in. So it can be, provided in a skilled nursing facility, their own home, and assisted living. We also take care of patients in our community who are unhoused, and there are, hospice nurses that meet someone who is on hospice care at a shelter, bring them supplies, bring them, give them care, help manage their medication. So it can be given in a variety of settings.
Great, thank you. CM, would you like to go next?
Thank you again so much for your wonderful talk today. My question is a issue that has been impacting various levels of care, but has been particularly an issue of palliative care is the caregiver shortage. I was wondering if you had seen any interventions that you thought were particularly effective in addressing this shortage, and if so, what do you think made them effective?
Yes, good question. One change that we're seeing is nurse practitioners becoming certified in palliative medicine and providing care both in the hospital and in outpatient care, and also on hospice. So I think, as in other areas of medicine, we are seeing what are called the mid-level practitioners. In palliative care, it's primarily nurse practitioners, but it could also be someone, a PA, someone who's a physician assistant, who becomes skilled. And there actually are certification programs for nurse practitioners who want to specialize in palliative care. So I think that is a way that we're seeing the access to palliative care being improved. Another way that we're seeing palliative care being opened up a bit is over the last 5 years, there are a few, maybe 2 or 3 trainings, specialty care trainings for physicians that do not require a physician to stop the practice they're in, move to a different city for a year to obtain that training. So they can continue their practice, do online training, and then several times during that year to year and a half of specialty training, they go to, for example, Denver. Colorado has one of the programs that is a hybrid program with online learning and in-person learning that then qualifies that physician to take board certification exam. They need to complete the fellowship and then take an exam as in other specialties. So it's the training plus the big test.
Great, thank you. And then Sasha, looks like you've got your hand up as well.
Yes, hi. I also wanted to thank you for providing such an informative lecture. It did really speak to me because my own grandmother has Parkinson's, and she's kind of I would say that my family is kind of classified as that kind of like fire department analogy, where I think that hospice and palliative care is kind of seen to them as something that's scary and fearful. And my question kind of goes along with the mental health component of that. I think that my mom, as one of her, she does have a few caregivers, but my mom also kind of serves as a caregiver for her. And I think that can be a little bit tough when you don't have that experience that nurses and healthcare providers that are focused in hospice and palliative care would typically have. So I wanted to ask how being involved or having that kind of services would support family members of those who require that kind of care, and what kind of things you've seen or experienced with regards to that. Because I think that it's definitely important for the family members of those who are undergoing hospice are supported and kind of understand how they might benefit from having people that are more knowledgeable and skilled in those services.
Great. So you're asking both for your family with a family member with Parkinson's, how can they get support with the care? And then the general question of how do families in this situation get support with the often formidable task of taking care of someone who is debilitated and who it's, I think, very heartbreaking. Despite everyone being involved with their care, being there, doing everything they can, the natural trajectory of Parkinson's disease is to get worse. So even though there's all this support, that person is actually declining over time. So I think looking for an outpatient palliative care program in the community that your mom lives in would be a good step. And if there is an outpatient palliative care program, then the support that would be received, there would be a palliative care nurse who would have scheduled visits to come to the home. Is your grandmother in an assisted living? Is she in her own home? Where does she live?
No, she's at her own home, and I think that kind of adds to some of the difficulties every now and then.
Yeah. So anyway, so they would come to your grandmother's home. They would do, a nursing assessment. They would look at her medications, find and do what we call medication reconciliation, to make sure that someone is taking the medications as prescribed. It can often be very, your grandmother has your mother's support, but we unfortunately often see, maybe a wife who is 87 years old and a husband who's 92 years old. And basically they have all the medications in a large plastic bag, and some of the medications in the plastic bag are things that the patient actually is not supposed to be taking anymore. They were hospitalized, their medications changed, but going home, it's not clear, to someone who's taking 6 or 8 or 10 different medications, what they're supposed to do and decrease the dose or increase the dose. So palliative care nurses can help with that medication management. Then there's also a social worker would come to the house, and would give information on any other kinds of support that the patient might benefit from, might be qualified for within the community. So there might be actually some caregiving that would be available. Certainly not kind of the around-the-clock care that's being provided now, but maybe some breaks for the current caregivers. And then also this ongoing discussion of, are you getting the care you want? Are you getting the care you need? If a crisis comes up, do you want to go back to the emergency room? Do you want to stay home? And what would that look like? If someone's involved with palliative care and they are declining and they decide they want to go to hospice, palliative care can help manage that transition. Outpatient palliative care, however, unlike hospice, does not provide around-the-clock crisis care. So if let's say, people who have Parkinson's are often at high risk for falling. Somebody falls at home and they fracture their hip or their arm, or they hit their head, then, that 911 is going to be called, and they're going to go into the medical care system and, probably get every single treatment that is recommended to them. So I think so outpatient palliative care, I think, would be an option to consider exploring for your family.
Thank you so much. That was very helpful.
Sure.
Great. Well, it looks like we've got, oh, Dr. Myers, if you'd like to go ahead.
You're muted.
I never learn. Thank you so much for this presentation. And I have a question, but and Sophie will continue the discussion after this to include some outside people, I suppose. But I just want to take a second to say thanks for doing this. We really appreciate it. And it's something that I think, in our program, there's so many things we could talk about, but in 1 year, you can't talk about everything. And it's good to have you do this today. We do talk a lot about social and ethnic and, other related factors in health and healthcare. And so I have a question related to that. To what extent do differences in family structure and care of the elderly amongst different groups factor into, your world of hospice care and, what you provide for maybe one group versus another? Not profiling, but just as a matter of how it works out. If you're working with a family that's from a background where there's grandparents and parents and kids all in the same place, etc.
So I think in palliative care and hospice, the social determinants of health are highlighted. Somebody has their own family structure, their way of communicating. They may not, the family may have family members that speak Korean and don't speak Korean, different spiritual beliefs. And that is a very important part of the care that is given. And we really strive to understand what the context is for that person and for their family.
Okay, great. So let's turn it back to Sophie, who will take final questions and then sign us off when this is all done.
Yeah, so if there's no other questions from the HAPI cohort, then I think we'll flip over to the chat, which it looks like, I know that there's been a couple of questions. It looks like, is it Lenore? I hope I'm pronouncing that correctly. If you'd like to potentially elaborate on your point, or no worries if not. But if there's anything else anybody else would like to add in, feel free to either jump in or put it in the chat, whatever works best.
Sophie, I did want to mention when we were communicating yesterday, you asked a question of how I came to palliative care. So I'll just take a couple of minutes to summarize. So when I went to medical school, I was like absolutely sure that I wanted to be a family physician. So that was my focus. That was my specialty training. And I practiced primary care for 20 years. And at the time, which was like many decades ago, that I practiced family medicine, we were trained to deliver babies. We took care of kids. We assisted at surgery. We admitted our own patients to the hospital. So that's quite different now, but that was the training that I had. Then after this many, many years in primary care, my own parents, I've lived in Santa Cruz for over the last 30 years. My own parents, who lived in Cincinnati, Ohio, were declining. And my sisters and I needed to go back regularly to support them, to help with their care. And as my medical group had sort of become more and more corporate, and so I wasn't allowed time off to go to Ohio to take care of my parents. So I decided that was not okay with me. I was very sad to leave primary care, but I became a hospitalist. So I worked as a hospitalist in our community hospital for about 10 years. And that's where I first saw what a palliative care team did. I saw tremendous suffering that people had at end of life. And our hospital had an excellent palliative care program at that time. And so I saw what palliative care physicians did. And I thought, that's what I want to do. So I did training in hospice and palliative medicine. I took the board exam. I continued to work partly as a hospitalist and partly as a palliative care physician. But then in 2014, I became the medical director of our community hospice and, left working in hospital medicine. And now, as I mentioned, I work on the inpatient team for palliative care. I'm going back quickly to the question about, how could palliative care and hospice be made more accessible? And what I would say is, I'm going to turn that over to you to make the differences in health policy and the structure of how medical care is given in the United States. You're the future of how things are going to be structured, what is going to be considered mainstream care and what's not. I think there is a formidable opposition to hospice and palliative care. But I'm counting on you all to make strides forward for us. Any other questions in the chat or anyone else? I think we're within a couple minutes of the hard stop.
Yeah, it looks like there's a couple questions in the chat. If any of the people who have written them would like to speak up, they're welcome to. I can also just read them from the chat if that's easier.
Perhaps I could jump in, Sophie, since mine was listed. My name's Leonore, so I'm up here in New York, and my comment really had to do with, organizational development. I'm both a patient at my age and a provider for many years, a psychologist at NYU. And, I've been really fascinated by how medicine has developed technically, but perhaps not humanistically, even though there are, humanistic seminars here and there. I thought your initial comment about how there's little or no review of goals and values by physicians who come and add their endless testing. That just seems to be true, endless testing, endless testing. So as a patient, at one point, I got a second opinion up at Dana-Farber in Boston, and I discovered that they are much more committed to a team approach as opposed to this fragmented care with testing. And I've just wondered if newer programs, rather than institutions of great longevity and great reputation, but perhaps not a lot of flexibility, might be the way to go. I'm acquainted with Diane Meyer at Beth,
Yeah.
at Mount Sinai, who's a real pioneer in geriatrics and palliative care. I think you could add geriatrics to your list of sort of low low respectability or small numbers of fellowships. It's just, doctors are being trained to cure, to save, to cure, and not to care for.
Yeah, I think that's the situation. So I want to respect your time. I think we are a bit past the time to wrap up. I wish we had more time to talk and to hear your questions, but I hope you'll take opportunities to talk with each other and in your sessions, in the HAPI sessions, to talk about these issues.
Yeah, thank you so much, Dr. Massion. I think we all have really, really appreciated your chat today. And yeah, thank you everybody to try and keep it as close to on time as we could. And I'm sorry the questions we didn't get a chance to ask, but yeah, thank you everybody for being here. And thank you for tuning in.
Thanks so much, everyone, and we'll see you next week.